We talked about everything from FHIR to SMART guidelines, to DPI, to financing, to Gen AI, and want to start with a brief show of hands. Who here has learned something that's really pushed their thinking when it comes to digital public infrastructure and FHIR? Everyone, that's great. Who has new skills, new hands-on skills that better equip them to go back and whether it's at their own organization or with a partner organization, better implement FHIR or better think about how to create digital health roadmaps that incorporate DPI? Garrett says yes. Awesome. Well, the next two sessions, the final two sessions of the day, are really about pulling all of these different threads together, all of this content that we've been learning about, all of these presentations, and really thinking about and learning from countries that have actually brought them to life on the ground. So first, we're going to hear a presentation from Sri Lanka. We have Dr. Pradeep and Dr. Udika, who are both clinicians and informatics specialists. Dr. Udika is leading the whole digital transformation for the largest hospital in Sri Lanka, over 1,000 beds, so that's no small feat. And Dr. Pradeep is leading the digital health transformation for the country at the Ministry of Health. And so they're going to share information and stories about how they've been incorporating FHIR and DPI as they've been thinking about their digital health roadmaps for the country. So without further ado, over to you.
Thank you, Anne. Thanks for everybody for participating today. And for the guys who are outside, you can skip your coffee because Sri Lanka is presenting, all right? So I'm going to present on this topic, how we adapt practically FHIR and DPI in Sri Lanka. I must say we are in the process of adapting, not fully adapted, so we're in the process of doing so. So I'll just explain a little bit about my country. So I'm from the Pearl of the Indian Ocean. So we are known as the Pearl of the Indian Ocean because we look like a pearl, it's shaped like a pearl, and it's in the Indian Ocean, right? So we are the Pearl of the Indian Ocean. And also because we're a beautiful country. So you must visit Sri Lanka. And when I visited Kenya, thanks for hosting us, I saw Kenya as a very beautiful country. For the first few days here, the people are the beautiful people that I've seen here. And we are going on a Masimara tour in a few days, tomorrow. And for the people who are going home tomorrow, they're going to miss a lot. Either you travel to Sri Lanka or stay here. So that's my advice. And a little bit about the healthcare system in Sri Lanka. We are mostly a government healthcare provider. The government provides 95% of in-ward care, and about 5% is only private sector. And all outpatient is like 50-50 split. And all the community care, we call it public health, and that is done by the government sector. So that was very handy in terms of handling the COVID crisis. So also, we provide free health care for the people of Sri Lanka. And of course, for foreigners, it's a nominal, very nominal amount. And we have about 1,600 healthcare institutions, tertiary care, secondary, about 80, primary care, tertiary, about 53 large hospitals. Dr. Udita is working in a large children's care hospital, one of the largest in the region. Primary care, we have about 1,000 hospitals. So we are the MOH officers are officers which provide primary care. So these hospitals are dotted around the country, everywhere. And we have a healthcare facility within the reach of average of every 5 kilometers. So accessibility is good. And because of that, our health indices, the national indices are relatively okay. We have a very good maternal mortality rate. As you can see, it's within the world average, and it's 29 and improving since 2018. Neonatal mortality is also good. Under 5 mortality, that's also good. And life expectancy in for Sri Lankans is 77 years on average. It's 81 for females and about 74 for females. So that's quite above the average for the region. And so we are proud of that. And we have achieved a little bit on eliminating a few diseases as well, infectious diseases like malaria, then syphilis and HIV. We are targeting on those. Then we have the expanded EPI program. And then we are also strengthening reforming the primary health care services. So these things are now happening. These are all from, not what we are saying, this is from the WHO website, so not just that I'm saying it, it's happening. So when you visit Sri Lanka, this is the beach in Sri Lanka. If you ever visit Sri Lanka, you can relax on the beach and be sure if you ever get sick, you'll be cared for in the healthcare sector that we provide. So look at the nice blue skies and the blue beach, because the next slide I'm going to present to you is going to amaze you. This is all blue, but very pale blue in Sri Lanka. This is the expenditure for healthcare as a percentage of the GDP, 4%. So we are doing all this with just 4%. I think the audience got just silent. And because now, maybe in your countries it's different. Because we have invested in, not in healthcare, we have invested in the human resource. We provide free health care, we provide free education, we provide tertiary health care as well, and education at the highest level, even postgraduate studies. So this is our investment in the human resource, and it's paying off. But we also would like to follow what is globally trending and what is needed for in the future to carry out better healthcare services. I wouldn't say our healthcare services are very efficient and very high quality, but it covers the basic needs. So we want to digitalize or digitally transform this healthcare system, and this has been happening for let's say roughly a decade or a little more than a decade. And we strongly follow this model by WHO, this leadership and the pillars, 7 pillars. And most of us, when we talk about earlier days were even now, we talk about services and applications. And we talk about the infrastructure, and that's it, right? Now we talk a little bit about more standards and interoperability, and that's why we are here. But we never really focus a lot on the workforce, legislation, strategy, and the governance. So what we, in Sri Lanka, we are focusing on that. And as I said, we are focused on the workforce for digital health. And we are kind of a model where we train medical doctors. I'm a dentist. I've been a dentist for 20 years. I started in 2021. This is my 23rd year or whatever. And I'm still practicing as a dentist. And I'm a specialist in health informatics as well. So I have an MD in health informatics. So same as Udit. Udit is not a dentist, he's a medical doctor. So okay. So we have invested in people who can drive this, who can take this forward. Because what we believe in sustainable systems. First, to make systems sustainable, you need to have the proper resources in-house, in land, in the country that you are working on. And also the finances, as I said, 4% of GDP, that will be mostly on salaries and the medicine, drugs. So we can't, stop drugs on medicine and healthcare equipment. As doctors, we know we need whatever we need at the hospital if you want to prescribe. That is more important. But this is very beneficial. So we have gone on a bit of a different approach. But of course, we follow the open architectures, the full stack. That is the open technology, the open standards, the open architecture, and the open content. So these are the current systems that are available. So as I said, private sector, little, only about 5% is engaged in healthcare, inward, but 50% in OPD, but there are EMRs there as well. So we have EMRs, electronic medical records, 3 major electronic medical records. We only have 3. And we have a district nutrition system, the national level systems for specific diseases, TB and malaria, and we have cancer and different registries. Then we have the maternal and child health aggregated data information system all over the country. So much of those systems are there. And these are the main 3 distribution of the main 3 hospital information systems in the country. As I talked to you about, it's scattered all over the country. So those are the healthcare institutions. Okay. And this is the slide I want to talk a little bit more on. So we follow, how do we adapt FHIR and the DPIs? We follow the open full stack. The full stack that we have followed, okay. Here, we can start here. This is the, we have the National Digital Health Blueprint. And on the blueprint, we have the Digital Health Platform. So that is based on the Open HIE. So the Open HIE, if you look at this, it's almost the Open HIE turned the other way around with a little bit of flavor, Sri Lankan flavor added to that. So it's a tea flavor added to that. So, and then we have the National Data Exchange. We have planned that and a National Electronic Health Record. So these will have be adapting the FHIR standards. They are already, FHIR. We have tested out the FHIR compliance and more compliance and more details will be given by Dr. Udita in the slides to come. So the standards that we follow are DICOM, LAWINC, ICD. I have not put all of those there. DICOM, ICD, LAWINC, all open standards, and we have a special number for healthcare patients that is also open. Anybody can use. So the idea behind the Open Natural Data Exchange is for other players to come in. You adapt our standards. If you can, if you are willing, then you can share information with us to the National Electronic Health Record. And then we have the open content. We have the national policies, the guidelines, and the security policies for sector-specific security policies and so on. So everything is open, and anybody who wants to refer them or adapt them then can come in. So finally, from my part of the presentation, a bit of thought-provoking slide. So by show of hands, who do you think is happier? The little guy. Show of hands, little guy. All right, not that much, right? Okay. The rich gentleman with the Ferrari. Nobody's there. Yeah, it's subjective, isn't it? Spending a lot of money. You may be happy, you may not be happy, right? Spending a little money, you may be overjoyed, right? Because his first toy, maybe a lifelike toy, those are opening, all right. So it's what we call, frugal innovations. Frugal, well, 55 countries are here, 50 odd countries are here. Most of the countries cannot afford a lot of things. So we promote frugal innovations, open standards, and that's where we are. And where we don't want to be is this. Okay, so I'm going to hand over to Dr. Udita to explain to you on the second strategy, that is how it is implemented at the ground level. Over to you, Udita.
Thank you, Pradeep. So my part is very short. I am here to talk about the connectathons we conducted. Connectathon is a connectivity test marathon. It provides a detailed implementation and testing process for, to enable the adoption of open standards for both the vendors and users of these systems, right? So the objectives of this Connectathon is, one is to provide, prove that the specification is complete, and also prove that the implementations that follow these specifications can actually connect. So those were the two objectives we tried to achieve with the connectathons we conducted. And we conducted a series of connectathons, 4 in fact. And we invited all the EMR developers who are working in Sri Lanka, not only from the secondary or tertiary care sectors. There were people who are coming from the screening side, the public health side. There were private companies involved in this. There were the Ministry of Technology, Ministry of ICT that is, and also some solutions were developed by the Ministry of Health itself. So there were a wide variety of community that came together in these connectathons. And for all these players, we had our, all our resources were open source. We shared them freely with everybody so that they can follow these guidelines and the IPS-based technical playbook that we wanted them to follow. So all those and all the content we had were published in GitHub open repository so that they could follow those standards and follow that guidelines, the implementation guides, and try to achieve the connectivity that we wanted to do. So all our learnings were shared through WhatsApp channels, and it was a very different kind of experience from what we were used to do in, say, when we wanted to run a project. It was a very informal a learning process because nobody actually really knew how to do a connectathon when we started. In the first connectathon, it was like we were clueless, but we didn't know what to do. But everybody came together and they learned as they go, and they tried to help the others who might be falling behind. In the first connectathon, what we aimed was to just to use Postman to just to share patients' registration details between two systems. In the second connectathon, we went further. We used local codes to and FHIR-based approach to share information about OPD and OPD encounters and screening encounters. In the third connectathon, it was where we fully went for this process, where we used international codes, used OCL mediation and OCL as the translator, and implemented the full ecosystem of DPI solutions using OpenHIM to achieve the interoperability between these different systems using standard code. So the second and third connectathons were actually supported by GEMB Healthcare Systems, so I want to give a big thanks to them. They facilitated this process, and from that we learned a lot. And the fourth connectathon was actually about learning and refining what we learned from all the previous connectathons. And it was more of how we analyze the data that we are going to collect through this platform, and how are we going to make use of that information to improve primary care, public care, and tertiary care. So that was basically about how we went from the conceptual document of the blueprint into the actual implementation. Thank you.
Thank you so much. That was fantastic. I think at this late stage in the program, having a picture of a beach and a Ferrari is exactly what we needed. I also really appreciated, Dr. Prandeep, the way you brought us back to the fundamentals of public health. I think we can get lost a lot in our IGs and our SMART guidelines and FHIR, et cetera, and often forget, we actually need a fundamental investment in workforce capacity and digital literacy to make all of this come to life. One quick question before we go to the next session for Dr. Prandeep. I think the audience and many that are looking to do something similar to what Sri Lanka has done would love to understand if you have any advice or key lessons learned, especially the way that you highlighted the investment case and how you managed to do this quite efficiently. Would love to hear maybe some advice for those who are interested in doing the same thing.
And sorry, I couldn't hear the question properly. What was the question?
So, any advice for other countries who are interested in following a similar journey to you in Sri Lanka?
Yeah, I'm sure. So, as I said, the initial investment was on the workforce. What we started was, of course, now as I think going on, most of the countries have legacy systems and so on. So, what we did was we invested in the workforce for digital. So we've had MSc, a master's course in medical informatics, and then health informatics MD course, where we train doctors in health informatics. So this is apart from the IT field. I'm not touching there because a lot of activities are there happening there. We have universities for who train ICT, and ICT personnel are in our setting. So I don't need to emphasize on that. They're really important. But the aspect I think the audience doesn't know is the aspect that we have trained others who would bridge the gap. There has been a big gap, and there is a big gap in healthcare, where the IT sector cannot penetrate into the healthcare sector as much as they penetrate into banking or the other sectors. Why? Why? Because we handle with complex data. No, in banking, what is the data that they handle? Okay, numbers and just a few. But we handle the majors, we handle, that has to be there, the history has to be there. So so I'm talking about mostly of information systems for healthcare, for clinicians, for decision makers, for planning, for public health, community-based healthcare. There is another arm where you have the financing aspects, that is definitely there. Then also for research and so on. So mainly if you're handling clinical data, you need to get the clinicians involved in the process of designing systems, implementing systems, and so on. So I think many forums we've discussed, we always tell, okay, technology is not the issue. No, the issue is implementing these things in the ground level, and most of the implementations, I'm sure the person who spoke from India in before the panel before this, they have a daunting task, huge country. Even if they say, you have issued millions of numbers for patients, that's just 1.5% or whatever, right? So for Sri Lanka, it's a bit of a different story because we are a small country, and we are like kind of trying to be an exemplar in terms of doing it with less resources and making it sustainable.
Great, thank you. Hello? Great. Thank you so much. And now we'll have Jacinta join us for a short presentation. I know we've all heard a lot about the Kenya Digital Health Superhighway. She's one of the brains behind that effort. Dr. Job from Safaricom could not join us today, but we're in good hands with Jacinta, so over to you.
Thank you. Just a small introduction. My name is Jacinta Gichuhi. I'm a software engineer with more than 6 years of health informatics experience. I work with one of the MOH technical partners to implement some of the products under the Digital Health Superhighway, and specifically I lead the implementation of the National Health Information Exchange. So I want to give you a brief presentation on how we are adopting open standards to ensure that we can achieve interoperability for clinical data. So just to start, for the National Health Information Exchange, we are building it using the OpenHIE standard, the framework, and just to give a brief of the components in it, and then see how it fits in with what we are building. We are building, how can I go back? Let's go back a slide. It's not working. Back. Thank you. So the components we're building is a client registry, which is already live with millions of client registrations. And these client registrations, when they are registered, they are assigned unique identifiers, which is what will enable us now to share clinical data, because they can be identified with similar numbers, in this case, in different facilities. We are building health workers that has around 50,000 professionals who are licensed and serving in the country. We are building a facility registry, which is still in line with the FHIR framework, that has data of all the licensed health facilities in the country. And then we are using a shared health record, which we are adopting open global goods product, in this case, FHIR server. And then, of course, all these components will be accessible. We'll need an API gateway, which is powered with a lot of mediators to ensure that we can actually make sense of the data that is coming in. So just to give you one of the use cases we have around use of standards. So these 3 registries that you're seeing here have been built using custom technology. They are not FHIR-based. So for us to be able to expose their APIs using standards, then you understand we'll need a service that understands the FHIR side of things and the custom data formats of the registries. So that means when a registration platform is sending data to the registries, it will send data in FHIR format, and then this data will be transformed to be able to comply with the formats that the registries understand. So this is one of the ways we are using standards to make sure that the data about the entities, which is very crucial in ensuring there is exchange of clinical data, because you need to know who is the subject of the data, who is the client in this case, who saw the patient, who is the clinician, and where the patient was seen, in this case, the health facility. So we are defining a Kenya patient summary, which is a customized FHIR implementation guide for the Kenyan use case. And in this case, what you're seeing here is a profile for an organization. So FHIR provides a way of transmitting different assets of data that are used within a clinical setup. So in this case, we need to customize this profile to fit our use case. I want to drive our emphasis on a property called address. So what FHIR gives us are these properties down here. It gives you city, district, state, and county. However, that doesn't map with the national addressing system of our country. Then you understand, we need to go back and customize it to fit our use case. Yes, the global standard, but customized within our use case, which has county, sub-county, ward, constituency in this case. So this applies to all the clinical data we are sending. So for the clinical part, majority of it will be to determine what data is required for us. When we are sending data about a clinical condition, what data is required for us? What are the value sets that are acceptable and actually used within Kenya? So just to emphasize on the same, the registries are built in custom platform. What you are seeing in this side is what the system understands in this case, but for us to conform to the standard to ensure that we can have data in FHIR format, then we are doing that transformation. The other bit is now on the clinical data. For us to be able to exchange clinical data, first we need to have a common understanding of the different terminologies in terms of syntax and semantics. So as part of the exchange is a terminology service, of which we are populating the registries with the clinical data sets for the country. That is procedures within Kenya, lab orders that can be ordered within Kenya, but again, mapped to the international standards. So we'll have a terminology service that is already populated with standards like ICD-11, that is for the diagnosis in this case, We'll have a procedure mapped to ICHI. We have lab borders mapped to LOINC. So adoption of these standards ensure that systems integrating to HI, which were already using standards, will not go back and redo the work. So another thing I want to take you through is how we are supporting the adoption of standard. And what I'm going to talk through is what will map to the connector zone in the Sri Lanka case in this case. So part of, in the setup of the systems used within the hospitals, you'll find some system very advanced and already comply to like 90% of the standard. In that case, what you'll need to expose to them is just APIs that they can consume to ensure that they are accessing patient clinical data. In that case, publishing data after a patient is seen and consuming data. So for that use case, you understand the systems are sending a FHIR payload, which is later sent into a storage, a FHIR storage. And in this case, the mediators, or rather the services that will be needed to do to facilitate this exchange is just for verification of things like we know the patient, we know the professional, we know the facility, and any other bundling of the data that is needed to ensure that data makes sense at the point of consumption. So we have another use case of systems which are they're not adopting to the standards out of the box. And for them, because there are many systems, so we have over 13,000 facilities in the country. You'll find 10 share the same systems. So we have many systems that will be connecting to the exchange, and we need to take care of the different scenarios. We have those systems that are FHIR compliant, the use case I've shown before, and then we have a use case of, yes, they have development team who are tech savvy. Yes, they can consume open APIs for HIE, so you just expose APIs and they are able to consume data and publish data. However, we have another use case of teams that really need to be handheld. They're not tech savvy. You give them basic APIs to consume, they're not able to do that. So those are the category of teams you sit down with to ensure that you can take data as it's coming from their system, and then have a set away of, in this case, mediators, to transform this data into what needs to go to the exchange. So here you'll see we are doing FHIR transformation because we'll have each system send data in their format, no particular order. Some will give you access to their database, and then you access the data, you do transformation, and then you're able to send that data in the exchange. Some will upload flat files, some will use SOAP APIs. So the task at hand that we are actually working on is to ensure that we are supporting all these use cases so that no one is left out, and we can be able to adopt interoperability in any form of our system. Thank you.
Amazing, great job. I think we had a little taste of track 1 and track 2 in this panel. In the interest of time, we're at time here, but I do want to allow a few questions from the audience, if there are any burning questions. If people came in late, we have Jacinta from Safaricom, who's been leading a lot of the FHIR work in Kenya. We have Dr. Pradeep and Dr. Udika from Sri Lanka, who've been really leading the entire digital transformation of that country. So I'm sure everyone has some questions.
Thank you very much. My name is Wande from Ethiopia, and I want to ask Kenya's experience in terms of just developing those blueprints. So one of my major questions is related with, come up with different partners working in one platform. Like, partnership. We do have a lot of private sectors and governments, ICT, and other agencies. How can we just, come up with, in one sense, in one shared environment, and then develop such kind of a framework or a blueprint for you? experience from your side and challenge from what you observed.
Great question. Who is that for? For everyone?
Thank you so much for your question. So we are in the process of building most of these things, and we can call the Kenya HIE a baby. It's still in the baby phase. And for it to be a success, different sectors need to come together, be it the registration bureau, be it a refugee department. So we are working with the different sectors to make this a success. They can give a use case of the licensing bodies in the country who license professionals and facilities. So it was a journey getting to where we are, where we have now a registry that is up and running. So, so first thing you realize there is trust issues. They're like, you want to get the data, are you replacing what you're doing? What are you setting up? So first of all is to explain to them what we are coming up with, and that phase was successful. So we were able to explain to them that we are just picking your data, but you still remain to be the authority of this data because you still remain to be the license, the one licensing these professionals and facilities. So it's a journey. It's not a straightforward case, but great milestone here so far.
No, I think the question was directed to her. I can share a little bit on our side as well from Ministry of Health, Sri Lanka. We've development of our blueprint was basically involving most IT institutes, IT professionals from different providers, as well as the ICTA, which is the Information Communication Technology Agency. Then we had the CELCERT, that is the CERT for Sri Lanka. And then we had the universities, IT university joining in, the providers, and then we have the specialists in health informatics, as well as we had an international technical team. I think my kind smart hat, Ron, he was part of that team from eShift from Canada. The exercise was very, very time-taking and very difficult, I'd say, to get everybody to come to consensus in terms of the architectures that we designed. And still, this document is living. So we've published the version 1, then 1.1 is not still there. So like that, because it changes. Because I don't think if somebody says, okay, we know everything about digital health and going digital, it's totally wrong. So we learn every day, so we change every day.
Great, that was a fantastic question. I feel like the combination of DPI and FHIR interoperability really enables those kinds of partnerships you were talking about with the public sector, the private sector, shifting away from kind of a monolithic system into one that enables more market-driven opportunities where DPI becomes like the public rails upon which innovation can really happen. So that was fantastic. I see a hand back there. You over there?
Thank you very much for the nice presentations. I'm Traimo Chaurura and I come from Zimbabwe and I work for the Zimbabwe government. So my questions are not going to be easy, I think, because we need to understand as governments. So to Sri Lanka, thank you very much. I think you are making good progress in coming up with a blueprint. But my question is the implementation. I hear that there's implementation deadlock because your health informaticians are all medical doctors and the ICT sector is lagging behind. It's just an agency which is lagging behind. What is their involvement in the continuous implementation and maintenance of the digital health infrastructure in your country? So basically I'm asking, how is the implementation going after coming up with the blueprint and everything else? Then to Safaricom, I would like to understand the terms of reference for Safaricom to be involved and engaged in this place. Are you the financier? or are you the steering committee, or are you maybe the secretariat, and what is the view of the other stakeholders and also the Minister of Health in Kenya? How is it that you're working together? We just want to know, because for what we know is Safaricom is a private player. So as governments, we want to understand how the government of Kenya is relating to you, the terms of reference sort of, so that at least maybe we can also try and, replicate your model. Thank you very much.
Me first, okay. All right. Tough question, yes. And thank you for that G to G question, right? So, yeah, implementation is a whole different ball game. So we one thing I think we explained is we have those strategy of keeping it everything open, and then we practically want to test it out before we roll out, and that's taking place, I think, would they explain. The third part is the very interesting part that you asked. How are we going to maintain this? The infrastructure, the connectivity, the networks within the hospitals, and also provide free of charge healthcare. So what we've initially thought was when the ICT agency took it over in about 10 years back, without kind of involving the Ministry of Health. They were a very independent body. They had the mandate to do it. And they started implementing systems, one system, but in different healthcare locations around the country. Regionally, chaos. Because 5 years down the line, you have to replace all the hardware, maybe maximum 6-7 years for a laptop. Then servers, 5-6 years. Networking, they break down. We have thunder and lightning. We are a tropical country, so it's really difficult to maintain. So who gives the money? Who does the maintenance? That's a very good question. So what we did was, now that we have the blueprint, we have curbed down. We are not now trying to implement systems all over the country. Let the manual systems be, and let them integrate. There is always, defining the scope, right? There are boundaries, and there are boundaries for digital and manual. So let that be. And within the hospitals that we have implemented, what we have done is, okay, we've tapped the government funding schemes. We have a budget line for maintenance, which was very difficult to get because of the healthcare budgets that we have. But we have that. And also we have maintenance agreement with within private partners and so on for a few years. So other than that, we have also trained our health staff, repurpose our health staff, train them in maintaining networks, troubleshooting. The plug is off, nobody knows how to do that. Just to plug it in, it's a very simple thing. But some of these people who are trained we've done a training session for 36 participants in the University of Colombo in network maintenance and administration. Fully funded course from government, and they worked for us for a few years, and now they are picked up by the private sector. So brain drain to other sectors, going out, big turnover is also a problem for our staff. And we also have institutional maintenance units where they do simple work, prophylactic maintenance, so to speak, and also troubleshooting. So that is how we have kind of tackled it in the short term. And in the long term, we are thinking, we have already put a cabinet paper for the parliament to approve a digital health bureau. So this bureau is proposed to be held at a certain level of governance, in the governance structure, where they have the mandate, the power, and the dedicated manpower, as well as the skill sets that are needed. So in that, we have identified network engineers, security engineers, and so on, those skill sets which are not currently in healthcare to be there. And also, we are partnering with the National ICT Agency and everybody. We are not running running to the left when they are running to the right. So we are running with them. So the current government, which you all know, maybe we changed currently there's a new government. They are very positive for digitalization and digital health. Hopefully we'll get the things done in that aspect. Thank you.
So maybe to take on the other question, the role of Safaricom in creation of the different products under the digital superhighway. So Safaricom is a private company, yes, but is working with the government across different ministries to achieve digitization of different domains, be it education, be it agriculture, and in this case, health. So Safaricom is playing the role of delivering some components within the digital superhighway, and also to coordinate the other partners contracted by MOH to ensure that all the products are delivered within the defined framework. So yes, Safaricom, in addition to being a telco company, is extending to, in addition to be a telecommunication company, is moving into a technology company, digitizing things outside connectivity. Yes.
Great, and I think we're at time. So thank you so much to the great panelists. We'll give them a round of applause. And